Hello. Welcome to our session on diagnostic innovations for the management of stem cell transplant challenges. My name is Steve Kleibacher. I'll be the moderator for our session. I'm the Chief Scientific Officer for Eurofins US. We're really excited to have a couple of great speakers for our session. First is Dr. James Ferrara. Probably needs no introduction. He's very well known in the field. Dr. Ferrara is the Ward Coleman Professor of Cancer Medicine and the Director for the Center of Translational Research in Hematological Malignancies at the Icahn School of Medicine, Mount Sinai. He's a well-recognized expert in the field of GVHD biomarkers and GVHD clinical and basic research. Extremely well published. Dr. Ferrara has well over 200 publications, peer-reviewed publications in the field. And with that, I will turn the stage over to Dr. Ferrara.
Thanks, everybody, for coming. Let's get started. So I'm going to be, full disclosure, this is about acute graft versus host disease, using biomarkers for acute GVHD, not for chronic. So the MAGIC serum biomarkers basically represent a liquid biopsy of the GI tract during graft versus host disease. So these two proteins, ST2, which is the soluble receptor for interleukin 33, and regenerative 3 alpha, which is a pro-survival protein for epithelial cells in the GI tract. These two proteins are released into the systemic circulation. Now, regenerative 3 alpha is in Paneth cell granules, and when Paneth cells and the crypts are damaged, they spill their intracellular contents into the capillaries and the systemic circulation. ST2 comes from a variety of damaged cell types, particularly endothelial cells and mesenchymal cells. But these two biomarkers together are put into a single equation, and they give an assessment of risk, which we call the MAGIC algorithm probability, or MAP. Now, for those of you who don't know, MAGIC stands for the Mount Sinai Acute GVHD International Consortium. It's about 24 centers in the US and Europe. We monitor approximately 650 to 700 allo transplants per year, with the specific focus of acute GVHD, the natural history of acute GVHD, and how we treat it. And we collect serum samples at about 8 times in the first several months of transplant, including at the diagnosis of GVHD and its initial treatment, and then weekly thereafter. And we've used these this natural history study to perform a probe-based trial design. So it's an observational trial. We don't tell the clinicians what GVHD therapies they have to use, but and they don't know the biomarkers at the beginning. So they are using their clinical judgment about what the GVHD looks like, but we collect the serum at the time of the treatment or the observation, and then we see what happens and how many patients respond to treatment, how many don't, and then determine the risk according to this probe design. So here are 250 patients who have onset grade 2 clinical GVHD. So that's a skin rash of maybe 60%, maybe a little bit of diarrhea, maybe none, but it's not severe disease. And what you can see is that these biomarkers will divide very clearly this group of patients into 3 separate risk categories that have different non-relapse mortalities at the 12 months after treatment. The low-risk category, where there's only about 10% non-relapse mortality, also has only 20% resistance to primary treatment. So most of the time that's steroids. Whereas the high-risk category, which we call Ann Arbor 3, actually has about 45% mortality and almost a 50% resistance. Now, if you happen to be listening to the GVHD sessions earlier today, you might have heard Dr. Kitko talk about biomarkers and acute GVHD. And she was using slightly older data. The data still hold up very well in all of these populations, with the exception of the fact that there are now more low-risk patients who get graft versus host disease when they get it. So it's about 60% now of patients are actually low risk, 15% are high risk, and about a quarter are this intermediate risk. And I'm going to come back to that later because it relates to a theme that we've heard already in this transplant meeting, where patients with graft versus host disease, many patients with graft versus host disease, are being overtreated with steroids, and they don't need the steroids that the high doses of steroids that we're giving, and we can use biomarkers to help that. Okay, so here's a case. This is a 43-year-old female with FLT3 positive AML in first remission. She had an unrelated donor transplant with flu-Bufore conditioning. She received TAC methotrexate prophylaxis. She engrafted on day 13 and was discharged on day 20. So completely vanilla transplant. She did very well. On day 29, she had a clinic visit. So this was actually her second clinic visit. And she had now developed a 60% rash over her trunk and legs primarily. She had 3 episodes of diarrhea, and her bili was 1.9 milligrams per deciliter. So the skin was stage 3. The diarrhea was stage 1. 3 episodes. We've done these studies. They don't know at home what the volume is, but we know that it's about 200 cc's per episode of diarrhea. So that's 600 cc's, that's a stage 1, and the bilirubin is stage 0. So this was acute GVHD grade 2. If her biomarkers were a medium a range of ST2, but a very low range of reg 3, that map is only 0.119, that's Ann Arbor 1. And if you sent your sample to ViraCore, this is what it would come back and look like. They don't give you highlighting, but I gave you the highlighting where it says less than 0.14 is low risk for severe acute GVHD and NRM. And you can see the reg 3 and the ST2. So this is a patient, if I had this patient at this point, I would treat with only 1 milligram per kilo of steroid if I were going to do that, and I would try to do a rapid taper because this patient is very likely to have a complete response to steroids, and you want to avoid that steroid toxicity. So if you've got the same patient and the same clinical presentation, and you send the biomarkers, and now for the purposes of illustration, I've kept the ST2 the same, but her reg 3 is now almost 100 times higher. It's 653. This now gives her a map of 0.317, which puts her into the high risk category. That threshold is at 0.29. And just to show you that these thresholds and these maps work whether or not the patient has significant lower GI disease. So this is a paper that we published now almost 4 years ago. This shows the use of the maps, and if you're high risk here, you're greater than 0.29. But this is in patients without diarrhea. There are still patients here, about 20%, 27% in the test cohort, 17% in the validation cohort, that have lower GI disease. That's CRIP disease that is not clinically significant in terms of diarrhea. So you want to treat that, but you would not know that because the patient has no diarrhea. So in this case, the map is more sensitive than clinical symptoms in terms of telling you who's got lower GI disease that needs to be treated. By contrast, here are patients that have greater than 500 cc's of diarrhea. So that would be like the patient that we just talked about. Here, what you can see is that the biomarkers still divide these patients into a low-risk group and a high-risk group. The high-risk group now is about 2/3, and their non-relapse mortality is worse. But you still have about 1/3 of these patients, despite the fact that they have lower GI symptoms, they have low-risk disease. So in this case, the biomarkers are more specific than the clinical symptoms because they're telling you precisely that these patients don't have CRIP disease and so therefore do not need additional immunosuppression. For those of you who are pediatricians, this works equally well in pediatric patients. We've just submitted an analysis of this in about 250 pediatric patients in our MAGIC consortium. The area under the receiver operating characteristic curve is a measure of the reliability of the test, the power of the test. The clinical grade at onset only gives you an area under the curve of 0.63. Whereas the map gives you an area of 0.84, so that's a highly significant difference. And you can see that when the patients are less than 21 years, you get the same 3 strata of Ann Arbor groups, and even when they're less than 12 years. So in every single group subset that we have looked at, the maps do act as a kind of liquid biopsy of the GI tract, which is in fact what drives non-relapse mortality. Those were all maps that were performed at the onset of GVHD or the initiation of treatment. We've also now looked at several hundred patients after treatment. Here we've got weeks 1, 2, and 4. If we look at the clinical response and that area under the curve that I was just telling you about, at week 1, so this is where we would normally say someone is steroid resistant or not, that area under the curve is actually 0.59. It's not a very good discriminator. At 4 weeks of treatment, which is the gold standard for clinical trials in GVHD, the area under the curve for clinical symptoms alone is only 0.7. If you look at the map, at every single time tested, it's significantly higher, starting at 0.81 and going up to about 0.84. And if you look at the very same patients and compare the maps that you have at week 1 versus their clinical response by week 4, those are the patients that are outlined in red here, you get significantly better information from the biomarkers 3 weeks earlier than you have in terms of the clinical response. So you can actually use it as a monitoring biomarker as well. And if you add the map to the clinical response, you get something that is essentially as good as the map alone. So to emphasize this, we've now looked at almost 850 patients in our database and biorepository. These are patients who have been treated since 2015 with systemic steroids and other agents as were needed. So if you just look at overall the response versus no response by week 4, you can see that about 72% of the patients respond, 28% don't respond. When you do the non-relapse mortality cumulative incidence, you can see that there. They're very large differences and highly significant. But it only gives you 2 groups, and it's not perfect. Let's look at this same group of patients, and now we're going to look at week 2, and we are going to use both clinical symptoms and the map. So what you have in blue here are the patients that are asymptomatic, so they've responded to treatment, and they have a low map at week 2. By the time you get to day 28, that's a 92% overall response rate. They're very low risk, so they only have about a 5% non-relapse mortality and over 90% survival. The patients, this is again at week 2, who do not have a clinical response and who have a high MAP are now, that's 11%, that's 10% of the patients, and they do terribly, right? They now have a 65% non-relapse mortality and only about a 20% overall survival. In the middle, if you look at patients who don't have a response, but who have a low MAP, that's one purple group, which is about 20% of the patients. And then another group is they do have a clinical response, but they have a high MAP. So we've put those two together, and when you look at how those do, they have intermediate results. Each of these curves is statistically significantly different from the next. And if you have a clinical response but a high MAP, so that's these lower purples, that's better. Sorry, if you don't have a clinical response and have a low MAP, that's better than having a clinical response and a high MAP. And you can see that difference in the survival curves here. So what this suggests is 64% of all of the patients that we have with graft versus host disease, you can tell by week 2 whether they're going to be in a very good group, an intermediate group, or a very bad group. And the very good group, that 64%, those are the patients that you could have started low if you didn't have a lot of clinical symptoms, but you can definitely do a rapid taper. And certainly at Mount Sinai, when a patient isn't on a clinical trial, I and most of my colleagues are now using week 2 as a benchmark and saying if you have a low MAP at week 2 and you don't have symptoms, we are going to start tapering your steroids fairly aggressively so that you can get off of it in 6 to 8 weeks. And the reason is that there is a real cost, medical cost, to steroids. We don't like talking about this because the data are actually hard to come by. But when we look in our own database at patients who are treated for graft versus host disease, and because we have about 24 centers in the MAGIC Consortium, and we don't, in the natural history trial, we don't prescribe what the treatment should be, there are some centers and some clinicians that have a very quick trigger to give systemic steroids, and there are others that will use topical steroids even for grade 2 GVHD and just kind of let them see where it goes, and so they wait before they give systemic steroids. And when we looked at this, when we looked at just the viral infections, we could see that the patients that get systemic steroids, high-dose systemic steroids, have more than twice the number of significant infections in the first 90 days compared to patients that get topical steroids alone. So when you start systemic steroids, we tend to taper very slowly, even though we want to taper quickly. And so the median cumulative dose in the first 28 days is 28 milligrams per kilo. That's a milligram per kilo per day. So we are now conducting clinical trials using this combination of low risk and systemic response to see whether we can actually avoid steroids. And here's how it works. So if a patient has Minnesota standard risk, and we do the biomarkers and they're Ann Arbor 1, we're starting with 1 milligram per kilo. If they wind up with a high MAP at week 1, they're off trial. You can now do whatever you want because they now have a high MAP. That's about 11% of the population. They only have a 54% overall response rate and an 8% non-relapse mortality. If they respond and they have a MAP of less than 0.29 at both week 1 and week 2, that turns out to be about half of all of the patients. And they have a 93% overall response rate by day 28 and only a 4% non-relapse mortality. Now, If they don't respond by week 2, let's say they flare or they have a high MAP, they come off treatment. That's about 6% of the population. They have a 10% NRM. Here's what's important. If they are stable at week 1 and have a low MAP, technically speaking, that would be steroid-resistant disease, right? Because they haven't had a clinical response. They haven't moved. But that turns out, if they've got a low MAP, that's about 21% of the patients. Those patients still have a 90% overall response rate and 0% non-relapse mortality in this data set. So those are, if you will, the slow responders, and those are also ones that you could wait another week, see what happens, and then continue on with your steroid taper. And then, of course, if they become a high MAP or they're non-responders, then the response rate goes down and the NRM goes up. So we've now defined, if you start with Minnesota standard risk and you are Ann Arbor 1 low risk, and you continue that way according to this paradigm, that's 69% of the patients, they've got over a 90% response rate and only 2% non-relapse mortality. These are the patients that could really benefit from lower steroid doses, and that's how we're starting to use the MAP to guide therapy when they're not on a clinical trial. So I'm going to stop there. Let me thank, in particular, John Levine, who is my MAGIC co-director, a lot of the other people who've run the biomarkers and done the clinical data, and all of the MAGIC centers both in the US and Europe. So I will stop there, and I'm happy to answer any questions you might have. One of the questions that I am most often asked is, how about patients with post-transplant cyclophosphamide as their prophylaxis? What's happening with them? So we've now looked at that. We're getting ready to submit a manuscript. The overall incidence of acute graft versus host disease in post-transplant site patients is identical to patients getting calcineurin inhibitors. It's still in the low 40s. What has changed is the fact that when those patients get graft versus host disease, more of them are low risk. They're Ann Arbor 1s when they actually develop clinical symptoms of the disease. So post-transplant, so they're low risk, but overall, when we've looked at this, post-transplant cyclophosphamide has not changed non-relapse mortality, and it has not changed overall survival. If we look sort of group by group, they are essentially exactly the same. So it's terrific that we can now do haplotransplants, but there's been, within the MAGIC consortium, there was a lot of experimentation with post-transplant cyclophosphamide for matched unrelated donors or mismatched donors. It actually has not changed anything. Okay, thanks very much.